speak about lifestyle, MASH, cirrhosis, and hepatocellular carcinoma. I will try to be quite not quite long. And next slide, just to tell you that now there is a new nomenclature. There was a multi-society Delphi consensus statement that changed the classification of what was called NASH, now is called MASH. What was called MAFLD now is called NAFLD, now is called MAFLD. And there was a revolution on the nomenclature, but essentially we can obviously compare what was the epidemiology before and the epidemiology now. It didn't change a lot. Next slide, please. The new nomenclature start exactly last year, so at the beginning of this year, and a lot of medical doctors don't know this new nomenclature. But what was called NAFLD was simple fatty liver, now is called steatotic liver disease, SLD, and it could be also NASH when an inflammation went on NAFLD. These two entities are now together in what is called MAFLD. And MAFLD means metabolic associated fatty liver disease, which it depends from the metabolic health of each individuals, from the genetic and the epigenetic of each individuals, and from the environmental, that means diet, alcohol consumption, and microbiota. And AFLD remained the same, and NAFLD became MAFLD, and it was also abandoned, the term NASH. Next slides. As you can see here, MASLD, metabolic associated steatotic liver disease, depend from different things and could give to us different symptoms, and in the progression of MASLD, we can see different disease, not only liver disease, but also cardiovascular disease. We will concentrate now about liver disease, and you can see here from a normal healthy liver, you can have fatty liver, and from fatty liver you can pass from fatty liver with inflammation, that means metabolic associated steatotic liver disease. And then you can go also to cirrhosis and to hepatocellular carcinoma. So the liver, we can say, is the mirror of our health. If we can look at the liver with different instruments, we can understand that there is a problem. It's like a red sign that appears in our car when we just drive, and when the red signs appears, it means that there is something that is not good and that is going wrong. Next slide, please. The global prevalence of MASLD is around 25%. That means 1 out of 4 across Europe, and most of them do not even know they have MASLD, but they have. This prevalence, 25%, was exactly the same prevalence that we determined in our Dionysus study almost 30 years ago. Now this prevalence is confirmed all over the world, and there are areas, as you can see here, where the prevalence of NAFLD, now MAFLD, was very low, like Russian, Alaska, very cold countries, and other countries where MAFLD prevalence was very high, like United States, Australia, main part of Europe, and also Eastern, like India and Indonesia, and some part of Africa. But mainly the Western world is the world where the prevalence of muscle D is higher. Next slide, please. The present and the future perspective of MAFLD is that now there is a high prevalence. There are not still any specific drug for muscle D. And as you can see in this graphic, in 1990, the most percentage incidence of chronic liver disease was due to viral etiology, either virus C or virus B, mainly virus C. And now that we have treatment for both HBV and ACV infection, the viral etiology is going to disappear, and we can have in our future perspective that the majority, the 80% of the chronic liver disease will be associated to a metabolic dysfunction. That means that in the future, MAFLD will be the most frequent indication for liver transplantation. Still now is the first indication in US and the second indication in Europe for liver transplantation. Next slide, please. Also, the predicted economic burden of MAFLD by country is going to increase in the future, and the economic burden of this disease is going to increase a lot in the next year, and even now is a lot higher, is very high. This is expressed in dollars, and we have $103 billion of direct cost of this disease in US, and the cost to the society is also very high. The total cost is highest in US, but not so low in Italy, as you can see here. Next slide, please. Yeah, this is direct cost. And now we can pass to diagnosis, a very brief update of a new diagnostic algorithm. So when we're going to find a steatotic liver disease, SLD, or a fatty liver, which is very simple to identify because we can identify it by imaging or by liver biopsy. And we know now that the prevalence of steatotic liver disease worldwide is around 40%. So back to the previous slide, please. Okay. We have to ask to ourselves another question. Does the patient meet any other cardiometabolic criteria when the liver is fat? Well, the adult cardiometabolic criteria are these one reported here, and the pediatric criteria, which are different, are reported here. When we have at least 1 out of 5 of these criteria present in a patient, so the answer is to this question is yes, we have to ask ourselves if there are any other causes of steatosis. If no, we are going to face a metabolic dysfunction associated steatotic liver disease. If yes, we should have, we were facing a metabolic alcoholic liver disease or another combination of etiology. If there are no cardiometabolic criteria in our patients, we have to ask to ourselves if there are any other causes of steatosis. If no, we are going to face cryptogenic steatotic liver disease. If yes, we have other specific etiology like alcoholic liver disease, drug-associated liver disease, or monogenic rare liver disease. Next slides. The next slides show you that the instrument, the tools that we have available now are very broad, and in MUSCLE-D or MUFFLE-D or METAFFLE-D now, we are not going to use any more liver biopsy. We use liver biopsy so also if we are going to do some trials and we want the gold standard, because liver biopsy is still the gold standard. But liver biopsy is a very invasive methodology, is risky, costly, and cannot be repeated over time. We have different tools now, like MRI or MRE, which can easily do diagnosis of fatty liver, but it's costly. This is going to become the gold standard in the future, but now it's very costly. We have ultrasounds, but ultrasound is very limited, very dependent to the medical doctor who is doing it, or to the technicians who is doing it. And we now have, we also transcend the elastography fibroscan, that with CAP, we can also quantify the amount of fat in the liver. Obviously, with the transient elastography, we have a better performance for cirrhosis by now than fatty liver. But I think that in the future, this instrument will be very useful also to quantify the fat in the liver and to follow up the patients that is doing treatment or drug therapy. Next slide, please. So we go to MUSCLE-D treatment. And just this very complicated slide is a slide that show you, or would like to show you, that insulin resistance is the main etiology of fatty liver, and what is the consequence and the progressions of fatty liver. And it should be also inflammation, and it depends also from a lot of immune signals. And as you can see here, in the progression of from an healthy liver to a fatty liver, to a steatotic fatty liver, to cirrhosis, and to hepatocellular carcinoma, there are also a lot of different risk factors, like, and there are also some other tissue and organs that are contributing to this, to the progression of this disease, like the adipose tissue that now is supposed to be very active, like the gut microbiota, which is a new organs that could increase the oxidative stress, the inflammation, the metabolic, the mitochondrial dysfunction, and contribute to the progression of NAFLD to NASH and cirrhosis. And also the single mitochondria are very important in this etiology of this multifactor disease. Next slides show you the next one, please. The next, okay. Which kind of treatment we have available now? We don't have now any drug that could be used with the specific indication of MASH, but we can treat MASH and MAFLD and have an improvement if we have an improvement of lifestyle. The lifestyle is what Giuliano showed very well, which is different in time, and is different also now in respect to 100 years ago. We have an approach here in our clinic in Locarno, which is a multidisciplinary intervention programs based mainly on physical activity and weight loss. We know that to lose from 5 to 7% of body weight at a rate of 0.5 to 1 kilogram per week and not more, through lifestyle modification, including dietary therapy and exercise, we have a very good improvement of lifestyle and also of MASH and MAFLD. We should reach at least 5% of weight loss to improve steatotic liver disease, and we have to reach at least 7% of improvement in MASH. And this was a very good paper of almost more than 10 years ago, made by Musso, who I think is following this webinar. I show him and the participant before. So is an old finding, but still very important for the multidisciplinary intervention program. Next slides show you that this is a new study. It was published this year in the journal Hepatology report, and it summarizes a controlled study made on thousands of patients that show that the UPF consumption, UPF means ultra processed food. That means all the food that comes from intensive cultivation, intensive crops, and intensive farming. All the ultra processed food causes the increase of an epidemic of type 2 diabetes and of obesity. And in this study, but it also in all the large-scale prospective cohorts that studied NAFLD or metabolic syndrome, demonstrated a positive association between these ultra-processing food and the presence of fatty liver. And most studies did not find any associations when we have a cross-sectional and significantly smaller sample size. But these cross-associations is demonstrated in all the study that compared lifestyle, diet, exercise, or physical activity, and the presence of insulin resistance, MAFLD, and metabolic syndrome. So what we have to do to change lifestyle and diet of our patients is to decrease and minimize the consumption of ultra-processed food, and increase the consumption of unprocessed and minimally processed food. We have to start to eat like our grandfather and grandmothers were eating 100 years ago. And we have to move like they moved 100 years ago. Possibly to have all food not processed. So what we call the 0-kilometer food, or food that not become from intensive farming or intensive cultivation. This concept is very important, and it's very important that you transmit this concept to all your patients with steatotic liver disease. By doing this, we are going to prevent the progression of steatotic liver disease to MASH, to cirrhosis, and to hepatocellular carcinoma. Next slide, please. Next slides. And these are the dietary pattern of our Western diet now. We usually eat more of what we can eat, so we should eat less in terms of quantity and in terms of calority. We eat a lot of saturated fatty acid, and we have to lower the saturated fatty acid to reach a correct Mediterranean diet. We eat low of polyunsaturated fatty acid, and we have to increase our unsaturated fatty acid and monosaturated fatty acid. We eat a lot of animal protein, and we have to increase the vegetable protein and not the animal protein. We usually eat now a lot of sugar and fructose containing food. A lot of food that we buy to the supermarket contain a lot of sugar and a lot of fructose, and we have to decrease the fructose and the sugar in our diet. We are eating a lot of food with a high content of cholesterol and salt, and we have to lower the cholesterol and the salt in our diet. We are eating a low fiber diet, and we have to increase our diet with fiber, with polyphenols, and with carotenoids. In this way, we are going to prevent the metabolic syndrome, we are going to prevent the steatotic liver disease, and all the consequences of the progression of steatotic liver disease, either to chronic hepatic disease or to cardiovascular disease. Next slide, please. The next slides. Just a few words on drug treatment. We usually reserve in our Integritas clinic here pharmacological therapy only for patients who do not achieve their weight loss goals, and possibly that they have a quantification of fat and fibrosis in the liver, quantitative. That means either with liver biopsy or with FibroScan mainly. the drug treatment obviously is different if we have an association with type 2 diabetes. And as you know, the steatotic liver disease or fatty liver is present in 80% of patients with type 2 diabetes. This is a very heterogeneous disease, and we have many other treatment options if the disease of metabolic syndrome or fatty liver is associated with hypertension, with cardiovascular disease, and so on. Next slide show you that a direct, a target therapy should fit on these different points, on lipid metabolism, on glucose and lipid metabolism, on glucose metabolism, and also on bile acid and lipid metabolism. Next slide show you that by now there are few drugs on the market, and these are this one, that could be used as indication of MASH or METAFLD, which are obeticholic acid, pioglitazone, but this is abandoned now, semaglutide or liraglutide that we can use at support of the lifestyle intervention. And the new one, which is an antifibrotic drug, is resmetirom. There is a new clinical trial published on New England Journal of Medicine on this new drug, but unfortunately it show only, probably 20% of improvement of fibrosis from a different stage to another stage, and this is going not to be so good. But there are a lot of research on this field, and also the drug company are investing a lot of money in new research on this field. Next slide show you that the target of the pharmacotherapy are very, are many hundred probably, and there are many trials in phase 2 or in phase 3 that are running now all around the world. Next slide show you that no approved standard is present by now, and show you the last 3 slides show you which is the workup of patients with the steatotic liver disease or MAFLD that we have in our clinic, lifestyle medical clinic. We have a specialist doctor that obviously visit the patients, measure body mass index, waist circumference, and as a general assessment of the patient problem. We also collect a food diary and a physical activity profile. We do some laboratory tests, a complete hemogram, ferritemia, serum lipid profile, a glucose profile, uricemia, AST, ALD, gamma GT, insulinemia, HOMA, the vitamins of the group B and of the group D, and homocysteine. We calculate metabolic score for steatosis and fibrosis, like fatty liver index calculation and FIB4 calculation. We do abdominal ultrasound and US fatty liver index calculation or Amaguchi score, which are semi-quantitative score for obtain a number of the amount of fat in the liver. Next slides. We also do liver fibroelastometry with FibroScan Go, and we calculate with CAP the amount of fat in the liver. and the amount of fibrosis, that means liver elasticity. And we know that now fibroelastometry is a method validated through the world by more than 3,000 publications, and is capable of measuring in a invasively manner both the degree of fat and the degree of fibrosis inside of the liver. And it often can replace liver biopsy, which is a very invasive methodology. We also try to have a personalized profile for treatment with supplement and vitamins. And we also advise our patients, if they are smokers, to go to a no-smoking therapy by experts that we have in our clinic here. Next slides show you that after all this work, we apply what we call the multidisciplinary treatment for lifestyle intervention. That means that if it's necessary, we consult psychiatrists, psychotherapists for a cognitive behavior approach. We have some other nutritional and dietitians that collaborate with us and act as a lifestyle coach. And we have also a personal coach, a physiotherapist or ergotherapist or physical activity educator for the personalization of physical activity and for education on movement, food shopping, and healthy cooking. And if the patient has an alcohol addiction, so we consult another psychotherapist or a center which is dedicated to the recovery of alcohol addiction. Every 3 months, there is a general discussion as a sort of there are oncology board. Now we name this metabolic board between all the specialists involved in the treatments of each single patient. Next slides. I think I finished. The next one, please. Show you. Next slide, please. Next. The take-home message. Previous slides. The first slide of the first take-home message. Can you go back, please, of one? Can you go back with the slide? Go back. Okay. Show you that. No. Go back. Okay, thank you. Steatotic liver disease is a complex, dynamic, heterogeneous, and multifactorial disease with several oxymorons. Wrong lifestyle is the cause and is also the solution of MAFLD MASH. And lifestyle change and are the right solution to prevent Mash-cirrhosis and Mash-HCC. In terms of pathophysiology, insulin resistance state, the lipid metabolism, microbiome, and also genetic variants are important. And steatotic liver disease is the hepatic manifestation of the metabolic syndrome. And since each patient is unique, we have to use personalized and precision medicines, which is the most complete tool to allocate patients into lifestyle intervention or therapeutic management. Next slides are the other take-home message, which show you that the multidisciplinary lifestyle intervention programs are still the primary treatment that should be started and can be customized to fit the patient's unique experience, meaning that although the Mediterranean diet is the best one, we have to add that the patient has to try to eat unprocessed food, especially all the carbohydrate should derive from antique grains, pasta made by antique grains, and not the normal commercial pasta, is the recommended basis. And it can be adapted on each individual needs. And the unprocessed food means that should be also low in sugar and saturated fat, high in polyphenol and healthy fats. And this is an evidence-based now treatment for the muscle build. The type of diet can be adapted to the patient experience and preference. But again, unprocessed food should be always preferred. There are currently no approved medication for the treatment of NASH. The best evidence so far is for lifestyle modification and weight reduction. Drug approved to treat associated comorbidity may be considered in relevant clinical setting for all the patients with MASH. Last slides, I thank you for your attention.
Yes,